Good afternoon, everybody. Thank you for being here with us tonight. We have the great pleasure to have one of the most prominent speakers in the world. I would ask Professor Afzal Javed to introduce to us the famous Norman Sartorius. We are grateful for him to be here with us and share some of his wisdom with us. Afzal.
Thank you very much, and greetings from World Psychiatric Association. It is indeed a pleasure and privilege that under the leadership of Professor Fontolakis, we are continuing with these Meet the Expert and the exceptionally great people's contribution to the field of psychiatry. Today's speaker is not an individual. He is a legend. He is history, and he is a role model for all of us and for the future psychiatrists. The work which he has done has inspired thousands of psychiatrists, trainees, students, and more importantly, policymakers. His contribution to psychiatry is enormous. While he was with WHO, leading the WHO division, he was instrumental in convincing the policymakers. When he was president of World Psychiatric Association and European Psychiatric Association, he was actively involved in promoting psychiatry and mental health, not only among those who decide, but also among those who really practice and who get it implemented. Today's topic, which he is going to speak, is actually a word of wisdom. Over the years, he has conducted a number of leadership training courses. And when he is conducting these courses, he is always mindful that what a psychiatrist should look like, what a psychiatrist should do. And I think with this legacy, he has been able to tell all of us that how should we pose ourselves, what should be the future workforce, how should we not only look like, but also do the work. So, Sir, Professor Norman Sartorius, we are grateful to you for joining us, and we always look forward listening to you. Over to you.
Thank you very much, Professor Javed. Thank you also very much, Professor Fontolakis, for including me in this series, which I'm sure will be of interest to people because of the excellent group has already been selected and who spoke in it. Now, I would like to talk today about the future workforce. And let me do this and just show a few slides with this. At present, I think, and for a long time now, we have seen that the areas of interest for the mental health programs in general are those that are listed on this slide. We believe that the mental health services and psychiatrists should be concerned with the treatment of mental disorders. They should find ways of supporting and caring for people who experience mental illness, and not only by giving them treatment, but also by advising them and making it possible, perhaps with the help of social workers or others, or the community at large, to make them live with their illness and survive it. I think that we have also included into this task a support of people who care for those who are mentally unwell. And these are very often or always carrying a major part of the responsibility and a major part of work to help the people who have been struck by mental illness. We have also expected a normal mental health program would at least invest some money, some time, and some personal involvement in fighting against the stigma of mental illness. Equally so, the other tasks of the mental health programs have been the secondary and tertiary prevention of mental disorders, some primary prevention of mental disorders, I'll speak about this later, and of course, what has been called the promotion of mental health. Now, today, the responsibility and the engagement of the mental health workforce is, as indicated on this slide. The number one priority that people see as their task is the treatment of mental disorders. A second of importance is some support to carers, some work against stigma, personal and social stigma, and some work on the secondary and tertiary prevention of mental disorders, that is reducing the number of people who will be disabled or helping those who are disabled to be accepted in society and find a job for them. The other three tasks, I think, are not so very much in the focus. It is somehow taken as a normal that people who are relatives or friends or acquaintances of people with mental illness will be looking after themselves while at the same time helping people who have experienced the disorder. Primary prevention has been declared impossible, and therefore very little is done for it. And the promotion of mental health, not so much in the sense of reducing the number of people who are mentally ill, but in the sense of raising mental health on the scale of values that people have when they decide make decisions, is also not particularly not given particularly much attention. So that is the current situation. And I think as we think about the century to come and the years to go, we have to think whether this will really is satisfactory. My own opinion is it is not satisfactory. And we shall have to think about the future in a different set of priorities. Yes, we will have to continue worrying about the treatment of mental disorders and supporting people with their mental illness. But the three major tasks that are before us is to thinking how to support people who provide care for those who are mentally ill, because they carry most of the burden. Many of the carers will, in fact, today, even find that by experience, they will know what medication to provide. And in a way, their role is every day growing and becoming more important. I think that primary prevention and the promotion of mental health will be also becoming much more high on the list of priorities. And I would see that these three priorities will pop up much higher, and the things that we have until now considered as being the top priorities will gradually recede somewhat in the background. Now, what do we do at present for the carers, for people who look after the mental illness? We shouldn't forget that the ideas about the community mental health, the modern ideas, have in fact been introduced in the middle of the 19th century. One of the great introducers was Professor Griesinger, who, having come back from Egypt, where he has seen that families look so well after the mentally ill, felt that maybe one should really change the nature of treatment and think of having a patient in the hospital or facility for a short while and then bringing him back into the community. And that is what has been considered as being a useful model of working with it. And so it is somehow been taken as normal, expected, that we shall, that these people in the community will be looking after people with mental illness, both those who are their relatives or friends and others who are members of the community. And this, the support which has been given to them has been to the carers, usually, if at all, some financial support. Very often, psychiatrists have giving some information and some advice, not particularly, not spending too much time on it. They give some lectures about how care should be done. They also express their sympathy for the task which these people are doing, and they recognize it, but they are not making a big spiel out of that. So this is what basically they get. And their friends and others who surround the carers, the person who provides care, vary in the way in which they experience this. Some respect this and acknowledge that they are doing an important things. Others withdraw from them because of the stigmatization, which very often spreads from the person who is ill to anyone who looks after him or cares for him, so that the whole family becomes isolated more and more. But here is the present support for carers. And this is a, if at all existing, a really miserable support. What we would need to think about adding to people who are carers is at least to assess the capacity for care. At present, in the whole of Europe and in the whole of the other countries that I've been able to look at, there is not a single document that says what must be the minimum capacity of the family in order to be able to accept a person with a mental illness for care. Imagine a small family which has the husband and wife. The husband, shall we say, falls ill. The wife looks after 3 small children and after an elderly demented parent. Is this family capable of accepting a person who has just suffered a very severe illness or who suffers still from a mental illness? And there are no criteria that we would say this is the minimum that must be available in order to be able to entrust this family or these carers with a task to look after yet another person. We should think also of direct help. We should think about arrangements which will allow people with who have somebody in their care some free time. There were wonderful examples of the recommendations of the Danish child psychiatrist for who has the lady Anneliese Dupont, whom I remember with much respect. She has in fact suggested that perhaps mothers of mentally retarded children should create a group so that any one of them will in fact be able to take a day off while the others will look after their children. And in some places, the, so to say, care holidays have been introduced by which a person who is severely or long-term ill will be admitted to hospital, not because he is unwell, but because that would liberate the family to take a week or longer to be to come back to their normal self, to recover a little bit from the enormous task which they have been carrying so well and so silently. But there are other arrangements that can be done to help the carers live a life that is decent and a life that is not destroyed by the fact that he has or she has to look after another person who is severely ill. We should also give them recognition for the fact that they have done such excellent work. The Royal College of Psychiatrists in Britain has done the wonderful thing that they select a family every year as being the family that has done most admirably for there. But there are various other ways in which we could recognize that that carers are doing such a wonderful work. One of the things that would be extremely helpful is to allow and invite carers to come and teach at the medical school to medical students about care for people at home, because they know much better than any one of us how you have to look after a person who is not well when you're at home. Giving them an opportunity to teach would not only transmit useful knowledge to the students, but would at the same time also mean that we are really recognizing that they know something which is valuable and that they are therefore all the more useful members of society. We should also think of the fact that it is well documented that people who look after a sick member of the family have about 2 times more attendances at general health care services. Their physical health suffers significantly from having a person in care. So we should think of how to facilitate the treatment for these diseases which come along, making them less weight, for example, or do something else that we could do to make sure that they are looked after also for their physical health and for their mental satisfaction of being what they are. And we should listen to them when we are thinking about care and about organization of care. This is the minimum that we have to do for carers. And I think that we should also give them some money because we are saving enormously by having them replace institutional care. So why not give them 10% of what we would have paid for a hospital care to look at after their patients at home. We should think also what we can invest as money into the organization of peer support organizations, which can provide some care to people who are not related to them, but who are also having a disease about which they know quite a bit and about which they can give good advice and also some empathy and care. We should also educate the carers about illness, both their own possible illnesses and illnesses that the person in care has, and facilitate the access to care for them, giving them a telephone number which they can call whenever it is necessary to proceed with care. 90% of people with severe mental illness will probably in the near future be looked after by one or two other people who are very often in a small nuclear family. We have to think of how to maintain that support and how to make sure that these people can do it properly. And then, of course, we have to think about administrative arrangements and legal arrangements. For example, a reduction of the work time at work if they have a person, or various other things that one could do. And one could learn from the carers of what they most need, and we should listen to them. Now, the second neglected area that I mentioned earlier is the primary prevention of mental disorders. And if you speak to people in psychiatry in general opinion of psychiatrists as well as others is that mental health programs contain practically there is no chance to do any primary prevention, and therefore they give no time to this particular task. Is this true? Well, maybe true at present, but we should understand that providing primary prevention program and intervention is of great importance. I'm listing here a few very simple ones that would cost nothing and would at the same time be enormously helpful. Take, for example, the provision of iodine to pregnant women. Now, this is not done universally, and every year, several million people are born with cretinism because their mothers did not have sufficient iodine during their pregnancy. It's a primary prevention of a severe mental disorder, a severe burden for the community. We should think about screening for minor sensory deficit. Practically all of the countries in the low income zone will in fact have none or very few checks of whether the children who are in school or that age of school hear well and see well. Now, a child that doesn't hear well will in general have more difficulties in school. He will be considered as stubborn and misbehaving because he doesn't listen to when you speak to him and doesn't understand what you're saying, even when he listens. And very soon, such children will become dropouts from school. And very soon after they've been dropouts from school, they will be exposed to all the dangers that exist for a dropout from school, from drugs and crime to physical illness and problems of a major kind. We should find people who have minor sensory deficit and do something for them. Minor deficit in, for example, myopia is very often discovered because the children tell you they cannot read. But deficit of hypermetropia is not discovered. And a large number of children will, in fact, with hypermetropia, be having difficulties reading, and therefore will be sent in countries where such services exist to be treated for dyslexia. And basically, they will also fail in school. And a simple test which would take both into account would be very important. Not to forget that in some countries, in fact, the discovery of a minor sensory deficit was on purpose disregarded. For example, minor myopia was disregarded and minor this hypermetropia, because it was considered, as we know, that minor hypermetropia does correct itself somewhat in the time of puberty, of adolescence. But the lost years of not being able to read or follow school is not taken into account at that time. We should also think about known factors that are high risk for mental illness, such as a mother's mental illness, or the frequent hospitalization of child, and add to the normal care an element that will make sure that they do not end up with a mental illness because of these risk factors, of which we know very well. And of course, a major problem that is of economic nature is that hundreds of millions of children in the low-income countries are in fact stunted. They have not developed as fast and as much as they could have developed had they been given appropriate stimulation and appropriate food and appropriate care. And we should recognize that the fact that they don't eat as they should be eating and don't look and are not stimulated and cared for as much, that in fact this creates a huge increase in the risk for a mental disorder, alcohol and drug abuse, and a variety of other problems. So there are undoubtedly possibilities for primary prevention of mental disorders, and it should become one of our priorities. There are other examples as well that I could list. For example, we could think of active and permanent effort to participate in perinatal care. Now, there are very few countries in which the normal perinatal care programs include elements of mental health, not only to discover depression, which may occur in the last months of the pregnancy, but also thinking of other high-risk events that happen, and also of the extraordinary opportunity to help mothers and fathers while they're expecting a baby to tell them and teach them about ways of bringing up children, about parenting, about risks, and a variety of things like that. And parenting education in itself is a hugely neglected thing. Practically nobody is in fact organizing appropriate parenting education. And we are somehow having this crazy idea that people are born with a capacity to be fathers and mothers. Well, they are not. And they make a huge number of mistakes which could be avoided quite easily if we did some parenting education in a regular way. There is very little effort also to link psychiatric services with school programs and in programming education and ways in which education is done. All of these are opportunities for primary prevention which are currently not being used. Now, the third neglected area, which I think it should be really given appropriate attention, is the promotion of mental health. Now, as you know, promotion of mental health can mean three things. It can mean, number one, the reduction of mental illness. The number of mentally ill people in a particular community is reduced, and we say the mental health in this community has been promoted. All right. The second one is we can think that the promotion of mental health is if we increase the higher resilience of people, make them achieve a variety of things, learn and develop, and so forth. The third way of thinking about the promotion of mental health is in fact different, basically different. And that is that the promotion of mental health is a process by which we are bringing mental health higher on the scale of priorities of individuals and societies. That they think about mental health as being a precious thing for which it is worth making sacrifices, because mental health is so important for life of quality. And that is something that we are currently not doing. So that mental health is ill-defined, not particularly looked after, and certainly not sufficiently, there's insufficient effort to promote the value that people give to mental health. I think that all three of these aspects are important and should be given incomparably more attention. Now, how do we prepare ourselves for these tasks that I here mentioned, or some of them that I mentioned? Number one, I think we should significantly invest into the revision of the way in which future doctors are selected. It is not the one who has the best marks in secondary school who is likely to be a good doctor. We know many of the personality characteristics. However, there are very few countries which really pay sufficient attention to advise young persons who want to enter into a particular postgraduate education or graduate education, what would be the best thing for them to do. We should think much more about what is it that we really want to find in future doctors and select youngsters insofar as possible for who will be likely to achieve these goals. We will make mistakes, that's for sure, but in many instances, we will not make the mistakes, and we should recognize the empathy, the capacity for empathy, or the interest in human things, or the capacity to make the way in which a people are built, which makes them better candidates for good doctors. We should certainly revise the undergraduate and postgraduate education. I'll say a word about this in a moment. We should examine the laws which are regulating healthcare and make sure that every one of the laws that we have about health and mental health has a sunset clause. There are still countries which are having laws which are obsolete, maybe 20, 30, 40 years old, and they have not been revised at all. In the future, every law that we produce should say, here is a law which we are putting forward. It's based on today's knowledge and today's society. In 3 years' time, we have to go back to that law and see whether it's still appropriate for the society at that point in time, at that point of development of science, at that point of the legal situation as it has changed. And the sunset clauses in all of our legislation would have to be introduced. Not to mention that, of course, since we didn't do that in the past, we should probably think of revising or at least reviewing the mental health legislation as it currently exists. We should think about introducing much more about health into the general education, not the old traditional style, only wash your hands before you eat, but really think a little bit more about ways of promoting health and give it a decent place in the general education, so as to increase the self-help capacity of people, so as to increase the capacity to help others, so as to increase the capacity to accept people who have disabilities, and so forth. And this particular thing, a very large proportion of people are imperfect. And thinking of accepting those who are particularly imperfect is very important and has to be done. And I hope that we can think that we shall introduce an appropriate component, an appropriate time and effort into making people ready and willing to accept people who are imperfect and help them to survive and live a better life. Now, we will also have to think about the personality of the future doctors and and the personality in which what we are going to search for is the capacity for empathy, a sense of justice, things of this kind, and acceptance of cultural differences. All of these things are very difficult to add to persons who don't have them. So we would do much better for ourselves and for the medical profession and for the psychiatric profession if we selected people who already have these characteristics. It will not be easy to attract them to come to psychiatry, and we'll have to make an effort to change a little bit the image of psychiatry, and also to make sure that we pay sufficient attention and respect to these new things that we are thinking. And therefore, we also have to make the workplace for people who work in psychiatry much more attractive. And the challenge is in front of the government, because the fact that we do not have a standardized cadre, good people who will in fact help to promote mental health in its three senses, will produce a huge burden on society, and society has every interest in the world to do something about this. Now, psychiatrists in the future, well, in addition to what I said earlier, I think that we have to think that psychiatrists of the future will also have to have something else. Number one, they should be expert users and teachers of communication skills. You look sometimes at psychiatrists today, they are invited to come and speak on television. Are they competent speakers? Do they in fact convince the audience? Perfect, very good speaking can be learned. It's one of the communication skills. And doctors should in fact be given, particularly psychiatrists, should be given a variety of communication skills. They should learn how to negotiate. They should learn how to convince. When we speak about making sure that women are receiving iodine at during their pregnancy, it is not the psychiatrist who will go and give the iodine. It is the psychiatrist, however, who should convince the government to do it. And in order to do the convincing, he has to know how to do this. We should start thinking and do much more to find ways to deal with comorbid mental and physical disorders. We see a huge increase of comorbidity of mental and physical disorders, and at the same time, in parallel, a fragmentation of medicine into ever smaller disciplines, so that nobody deals with all of the diseases anymore. It's psychiatry deals with the depression, and diabetology deals with the diabetes, and there are 3 other doctors who deal each with a little piece. And I think we have to think of organizing the care in a manner that will ensure that we simultaneously approach the variety of comorbid diseases that are present. People die because of comorbid diseases much sooner than they would otherwise. People with mental illness die 15 years earlier than people who do not have mental illness, not because they have a mental illness, but because they have a mental illness and a physical illness, and the comorbidity is managed so miserably. Of course, the psychiatrists have to remain competent in their own field, know about psychiatry and its treatment, and they should start also thinking of being not only doctors in treating the illness, but also advisors about ways of creating a life after an illness, which very often lasts a long time and certainly influences a person's life so much. They will also have to accept and be willing to work and listen to people who have experienced mental illness, to people who have been looking after persons who have a mental illness. And I think that listening and being able to accept that we psychiatrists are not perfect, nor do we know everything that we need to do a good service, is of tremendous importance. And as I said earlier, and I repeat it, having empathy, not only for those who are mentally ill, but also for their family, for colleagues who work with you, and for the miserable suffering in the general thing, is an important feature of a good doctor, and a particularly important feature for a good psychiatrist. So, ladies and gentlemen, I think that the world of tomorrow will bring many of the changes, and most of those changes we can predict, and we know exactly what will happen. And I think we have to think of ways in which the focus will have to be changed of all medical establishments and doctors, including psychiatry, while at the same time remembering that no matter what changes we are doing, we will need to put enormous importance on empathy and technical competence going with it. I think that we can ease and make the future much better by employing a variety of effective measures now. We will experience the benefit of some of them, but those who come after us will be very grateful to what we have done, because otherwise, if we don't do it, society will not be a nice place to live, and being ill will be a much greater problem than it ever was in the past. So I thank you very much for your attention, and thank you also for inviting me to participate in this series. Thank you.
Well, thank you very much, Professor Sartorius, for these words of wisdom. And I think the conclusion which you have really given, that is the way forward, and that is the future. We have got some questions. So should I just ask Professor Fontoulekas to ask to take any questions for you?
I think that Norman gave us, with his large experience from the international environment, gave us a very good idea on what it will be expected by a mental health professional in the near future. My main concern, and I would like to have your opinion on that, my main concern is that, especially with the pandemic, we witnessed something that we were suspecting, but we haven't seen in such a magnitude and strength, and that is the denial of existence of a pandemic, which is there with people dying, and still a lot of people denied the existence of something which was so obvious, which means that we will have probably much difficulty to persuade concerning mental health, mental illness, treatment for them, which is much more elusive in comparison to a pandemic. And we were also witnessed the mechanisms and the needs behind such a denial and such an alternative, let's say, experience of reality. Do you have any comment on that? Any ideas? I mean that the resistance to mental health is great and beyond logic.
Well, the pandemic, I think, had a number of expected consequences and some unexpected. For example, an unexpected consequence was the reduction of child mortality during the pandemic. There was an unexpected consequence was also that the suicide rates varied. In some countries they went up, in other countries they went down. All of these are, but a very important, unexpected, but very important event that happened was that governments as such, no country in the world, they acted as they should act. And there was a number of things that could have been done had we been prepared to do something about the pandemic. We have now learned what are the elements of a government response to a major threat such as the pandemic. And I hope that that will help us dealing with the pandemic. Now, the pandemic, however, had also other consequences. It increased what is called delayed morbidity. It's all the people who have not got vaccination, not for COVID, but vaccination for other childhood diseases, which has been postponed or canceled. All of the people who for 3 years long have not been discovered for their cancer of the breast or prostate cancer or other cancers, because these services of screening have not been in place. These people will be a burden that we will have to carry as time goes by. Now, thinking about mental health, however, one thing that we have seen is that there was a report that the number of people with depression and anxiety have grown. But I think it was an important message in that, because it is not that the number of people with depression has grown as much. There's an increase of the number of people who were depressed, but they were depressed for real reasons, not because they had a disease depression. They were depressed because they lost their job, they lost their time, they lost everything. And maybe they lost a relative and who died in it. So that one important thing that we shall have to distinguish is what are the relevant changes of mental health that we as psychiatrists have to deal with, and what are the consequences of events that can be only controlled by the government and by the society as a whole. I think that these are two different tasks. We cannot treat a depression which is due to the fact that one has been thrown out from his work. This is a thing that depends on the employer, not only on a psychiatrist. So that's another consequence that we have to think about. Now, maybe some other things that are important as well. I think that perhaps we have learned also of the necessity to increase the power of the health authorities, which at present not had much power at all. They were saying things and thinking about things, but they have not really had the possibility to introduce resolute measures when they were necessary. Another task that I think is before us is the question of the behavior of the health personnel. The fact that 30% of all health personnel in some countries refused to have vaccination is something that we should think about. I mean, this is a measure that for somebody, not only that the person's health will suffer, but these are people who also transmit disease as well. So why is this happening? Have we selected these people correctly? Have we done sufficient to educate them as time goes by? So there's a variety of changes, I think, that are important for medicine as a whole and for psychiatry, which should be a consequence. One other thing which is important and should be done now, we have seen that the stigma of mental illness has been particularly ugly during the time of the pandemic, that mental health departments have been emptied so as to create place for people with COVID. And the patients who were having mental illness were let to go out into the street and not given any treatment anymore. And there was a variety of other things. And the consequence was, of course, that there was the mortality of people with mental illness has sharply increased during the time of the pandemic, because on one hand, they were not given care that they should be, and the other, they were also exposed to very severe stigma. So it's a complicated business, and maybe at some stage, we'll have a chance to talk about the positive and negative sides of the pandemic and the ways in which we can deal with the future. These are just some thoughts.
I was mainly asking concerning a very specific thing, that a lot of people denied the pandemic. And this has similarities with denying mental illness. And in general, they had an attitude and a behavior which was uncooperative towards measures and treatments. So now let's forget the pandemic. If this is a generalized tendency of the public, my question is, are we going to face this in the future, not in the frame of a pandemic, but in our everyday clinical practice concerning the treatment of mental patients? I mean, this resistance to mental illness.
Well, I think that the education, or rather the creating of an attitude, creating of a character, creating of a person is happening in early years. And we should have to think of investing incomparably more in educating parents about the way in which they should educate their children, to make them capable of accepting, to make them capable of dealing with people who are not well. A variety of other things that we would like to see in adults. We are not seeing it in adults because the education at home has been continuously deteriorating over the time that we have before us. Take the impact of the women going out of the house for work more often than before. The fact that that has happened meant that the women have been given an extra load because they were supposed to do the things as they did yesterday, and at the same time, they had also their job on their shoulders. And the structure of the families have suffered from it, and the education of the children is no longer given the attention that it should be given. The schools cannot educate children alone. They can provide knowledge and some education, but the education which Aristotle and others have been thinking is important, of making people good members of society, depends on not only on the school, but on all of those who surround the child. And that is the family, which has to have time and wish to do something about it, which is the society with laws that are appropriate, which is also, of course, the schools. And I think creating people who will be willing to accept and to work is something that is a big task for the future.
Sir, I received one or two questions. One of the questions is very important, that you spoke about capacity building, you spoke about how to sensitize our future workforce towards the understanding of patient as well as carers' needs. So in addition to this theoretical work, would you recommend, with all your experience going globally, that what sort of practical aspects should be included in the training?
Yes, it would be very easy to recommend it. The more difficult task would be to find somebody who would listen, because so many of our colleagues, in fact, are convinced that what they are doing is perfect. I mean, there are so many simple things that that one could do. I mentioned one example of that is to sensitize a student of medicine into about the specifics of his work. One has to think a little bit more and not just of lectures on endocrinology. A colleague of ours, Dr. Herzlich, many years ago, she required that any person who is going into medical school in the second year spends at least 24 hours in a house with somebody who, in a house in which there is a very severely ill person, just to know what it means to have a severely ill person at home. And that formed the students. They thought about it much later. It was a very simple act, and it was something that was important. And there are numerous similar things that we could introduce into the training of medical doctors to make them doctors and not just people who have learned the books on medicine. Because being a doctor does mean much more than just really treating a disease. And I think that that is something that unfortunately in medical schools today is to a large extent still neglected. They learn the technology, but they don't learn the skills and the human side of medicine.
You are absolutely right that in our medical curriculum, especially at our undergraduate level, when we talk about mental health, we generally means a mental disorder.
That's right.
Whereas we are missing the gap between mental health and mental disorder, and that is the mental well-being.
Well, the general practice would benefit so much from having doctors who have understood a little bit more about mental health and mental illness. We had done once a little study, which I thought was quite interesting. We have asked the general practitioners to not say anything for 2 minutes, but just to nod and accept what the patient was saying. That was the instruction which we gave them. And then as the patients came out, we asked them, how was it? How was your interview today? How was the visit? And they said, well, I've never got so much good advice as this. This is a different doctor. And in fact, if you look at today, the average time in which that a doctor spends before he interrupts the patients when the patient comes through the door is 25 seconds. As the patient comes through the door, he says, so please, what brings you here? Patient starts speaking, says, I have a headache. And says, yes, when is it a headache, morning or afternoon? Patients are never allowed to have a few minutes, and the doctors have not learned the most essential skill, which is important for all medical professionals, which is the skill of listening. And I could go on listing skills of that type, which would have to be introduced, and they're not expensive to introduce into medical training to make doctors who are different in their nature. And the point being of all of this, that a doctor who knows how to listen will, in fact, in the long run, spend much less time with the patient than the one who doesn't. Because it's a different relationship that establishes itself, and by learning how to listen, you are in fact much more likely to take the right road to helping a patient.
We have got, sir, another question, and if I understand correctly, the question is that it looks like the exposure of certain information matters in terms of promoting, whether including promoting mental health. But at the same time, exposure can also be detrimental. So, will this make sense to increase the exposure of information to promote mental health and avoid any further stigmatization or complication?
Well, I think that we have just published a book on reviewing what is the novelty about fighting stigma. And I think that stigma of mental illness is undoubtedly the #1 problem that we have today in dealing with psychiatry. And I think that we have to think of fighting stigma as an essential time, an essential part of health services, which have to invest massively into thinking about what can be done about stigma. We know today that the most important method of reducing stigma is social contact of different types. And we have seen huge advances in promoting and facilitating social contact with people who experience mental illness and the effect that that had on those who surround them. But we have today a number of techniques which deal with stigma in a competent manner. And it is a great pity that these techniques and ways of doing it are not given much attention, no time, and no money. And I think that is something that is very sad and probably makes our services much less effective and makes our profession much more attractive. And we are therefore not getting the sufficient candidates who would like to learn all that we need to tell them.
Well, if Professor Fontolakis allow me, because there are so many questions and comments that we can have, but because of the limited time, I have got just one question which I would really like to ask, seen from the comments from our participants. You have done a number of leadership training courses. What do you think? How was that taken by the participants of these courses, the young psychiatrists, the young professionals?
Well, I mean, this is not, I shouldn't do this, but it's a time to be immodest because there was, in fact, I think there is unanimity. The people who went in those courses have spoken about them with very with much respect, and they had a very good time there. And I think that there are some elements of these courses which were contributing to this. One of the elements was that I think that we are treating people when they come to these courses, we are listening to what they have to say, and we are trying to build their capacity to become more prominent. And we are trying to be individual about learning skills. Different people can use different skills differently. Some people are very good listeners, others are very good talkers, others are very good smilers. There are recognizing what is your power and your strengths is very important. And many of the participants in the courses came away knowing more about themselves. And because of that, much more, they found it more easy to work and to continue their jobs. Some of them speak about life-changing experience, but that's maybe just a flattering way. But all of them have been recommending this course to others. And I think that we have usually a very large number of candidates for every single spot, which to me is a very good measure of how popular these courses are.
Well, thank you very much, Professor Sartorius. Professor Fontolakis, any concluding remarks? Because you are the initiator of this great Meet the Expert series.
Well, there is not anything to say after after a speech like that. It was both a pleasure and an honor to have you here, Norman. Thank you very much for your contribution to our efforts to educate colleagues around the world with this new way of teaching and communicating, which is the Zoom, the online platforms, which are maybe too technical, especially for us psychiatrists and psychologists. They are too technical, but still it's a powerful tool to bring people like you from the comfort of your house or office to an audience around the world. So thank you very much for your very valuable contribution.
Thank you for inviting me. I hope you
and thank you for writing the prologue to my book.
Thank you very much. It's a wonderful book, I want to say, and I would like to use the opportunity to promote it. I think it's a
You haven't read it. That's why you are saying it's good.
no. Thank you very much for inviting me. Thank you, Professor Javed, for your kind words and for introducing me with so much kindness. Thank you.
Thank you very much, sir.
Take care. Thank you, everybody, for being here with us. Until next time, have a nice evening. Bye-bye.